The next speaker is Dr. Anujeet Paul. Dr. Anujeet Paul did his Retinal Fellowship and is presently a consultant at the BBI Foundation, an assistant professor at the Vivekananda Institute of Medical Sciences, and a visiting consultant at the B.R. Singh Hospital, Kolkata. Over to you, Dr. Anujeet, to speak on retinal conditions that cause glaucomatous like OCT abnormalities.
So thank you very much, madam, and thank you, AIOS, for this opportunity. So I will be speaking on retinal conditions. Just a minute. So I will be speaking on retinal conditions that mimic glaucoma. So for all this while, we've been focused on the optic disc and the changes in the optic disc and how they can or cannot mimic glaucoma. So for retina, I'd like everyone to just sit back and just focus away from the optic disc, because as retina specialists, we have to look as far as the periphery for our diseases, and we have to correlate all that with the findings that we have with our investigative modalities. So even on OCT, we usually see our glaucomatous damage happening in the inner retinal layers, but as retina specialists, we are more focused on the outer retina. And sometimes changes in the outer retinal layers, the photoreceptor layers, have an implication on the nerve fiber and the ganglion cell layer, and which is why a retinal disease can in fact mimic glaucoma. So once again, if you look at the fundus, there's a healthy optic nerve and there's an optic nerve with glaucoma, but not all of it is caused sometimes by ganglion cell loss. Not all of it is caused by changes in and around the papillary region. Sometimes changes in the macula along the arcades can also cause a retinal disease to mimic glaucoma. So otherwise distinct retinal diseases can mimic glaucoma because of optic disc features, visual field defects, or OCT changes. So for the convenience, I've divided this presentation into retinal diseases that mimic on presentation and those that mimic on sequelae. So starting with those that mimic on presentation, we start with congenital anomalies of the optic disc. These are present right from birth. These include optic disc pit, optic disc pit coloboma, and morning glory syndrome. The fact that they mimic glaucoma is because of their large discs and the large cup, which is often misconstrued. So if you have a look at this photo, in general, it is a no-brainer photo for anyone sitting here. This is in fact a chorioretinal coloboma with a focal excavation of the retinochoroidal region inferiorly. But what if it presents like this? What if there is no other feature that is presenting? And this is when it can mimic glaucoma. So even though it is a bowl-shaped excavation inferiorly with some sharp borders, because of its non-progressive nature, in spite of being a mimic of glaucoma, we can differentiate it from glaucomatous cupping. Once again, I put to you another retinal disease. Once again, a very easy no-brainer. There is an optic disc pit, and this is very easily demarkable on indirect or direct ophthalmoscopy. So, however, what if it presents like this? What if the pit is not really visible? What if there is an area of neurosensory detachment over here, which is not sustainable and which cannot be detected if you're not seeing it on OCT? So even though on OCT, this is not a mimic because we can see the subretinal fluid from the ODP, the disc feature sometimes mimics glaucoma, and that is why we have to differentiate it with the OCT findings. Once again, another very, very common retinal feature. This is unmistakably morning glory syndrome, a funnel-shaped excavation of the disc with spoke-like vessels extending from the disc to the periphery with a central glial tuft. But what if this patient presents to you with a picture like this? It looks like a large disc. There may or may not be a central glial tuft, sometimes easily visible. There's increased number of radial blood vessels, which may not be visible, and this annular area of peripapillary atrophy may not be discernible. This is when conditions like morning glory syndrome can also perplex even a diagnostician to wonder whether this patient also has glaucomatous cupping. Another very simple retinal finding, there are multiple lumpy, bumpy features that I'm pointing out over here. And this is quite easily optic dysdrusen. These are the FAF and red-free images that show the same thing. But sometimes when there are a few, and when it is focal, when it is not easily discernible, so an irregular looking disc with a lumpy, bumpy appearance somewhere in the peripheral portion of the cup disc margin can sometimes mimic glaucoma. Over here, a red-free photograph, or like the OCT I showed you in the previous photo, can help us discern it from glaucoma. Superior and inferior field defects can also help in differentiating these, as well as its progressive nature, which is not there with the retinal anomaly. Some more very easy fundus features on presentation. So this is a large disc with a large cup, with an area of peripapillary atrophy, with a tigroid fundus, RP changes in the macula, thinning where you can see the sclera. This is unmistakably pathological myopia. But sometimes when the pathological myopia is not clearly discernible, there is not enough features to differentiate it, myopia also becomes a very important differential and a very important mimicker of primary open-angle glaucoma. So increased risk of primary open-angle glaucoma is also seen in myopic eyes. Large discs with a shallow cup with a shallow neuroretinal limb. Tilted discs with peripapillary atrophy and gross tessellation are some other features. These discs may also have very distinct visual field defects that mimic glaucoma, including arcuate field defects and large blind spots due to the area and region of atrophy. So moving on from those that mimic glaucoma, those retinal conditions that mimic glaucoma on presentation, we go to those that mimic on sequelae. That means otherwise normal, clearly discernible retinal features over time are confused for glaucoma. So the easiest one is retinitis pigmentosa. So retinitis pigmentosa will ideally present with one of the three findings, but diagnostically, we all know the triad of waxy disc pallor, arterial attenuation, and bony spicules. Sometimes the glaucomatous field defect of a constricted field can confuse us whether this disease is glaucoma or not. However, the triad will always help us differentiate RP from any glaucoma. Another very important differential are vascular occlusions. So vascular occlusions on presentation are very, very distinct. I don't think anyone would mistake it for glaucoma. But however, if you go into the sequelae of a vascular occlusion and go for a HVF of the patient, it will show you sometimes an arcuate field defect, which you will not find in glaucomatous patients. So following up these patients help differentiate otherwise vascular occlusions from glaucoma. Another very important feature is post-pan-retinal photocoagulation. Because of the extensive area of lasered retina, sometimes field defects, if we do not have a look at the fundus or the periphery beyond the arcades, we may confuse the Humphrey visual field for something that may give us an idea of glaucoma. So there has been a lot of studies that have debated on the amount of RNFL loss after PRP. Some studies concluding that the RNFL becomes significantly thinner. So this also raises a level of suspicion when you're comparing it in glaucomatous patients who already are expected to have thinner RNFLs. Finally, there is the last condition following any retinal disease, that is optic atrophy, which can happen even after neurological conditions. So it's very important to differentiate. As ma'am has already said, the extent of pallor is a very important factor to differentiate optic atrophy due to other conditions versus that of glaucoma. Thank you very much for your attention.
Thank you very much, Dr. Anujeet. That was a great talk on retinal disorders mimicking glaucoma, and definitely a very informative one as well. So we'll move on to a take-home message, maybe a two-liner from each of the speakers on your topic. We'll start with Dr. Chaudhary. What would you give your take-home message for those diagnosing glaucoma where they have an access to OCT?
When there is access to the OCT, my take-home message, always go for the clinical findings also. Don't be biased on the OCT. Number one, because there are some fallacies are always there. In every machine there is some good or some bad effect is there. And OCT has, most of them are the good one, but it has a fallacy, it has to be taken care of. So the clinical findings has to be taken as for the disc findings and others before interpreting to case of the glaucoma.
Thank you very much. As we always say, that clinical diagnosis actually is the priority. OCT is just an aid to diagnose glaucoma or even detect the progression of glaucoma. Dr. Shweta Tripathi, would you please give your inputs?
So as I pointed out in my own presentation, that there is a schematic, or I can say a rule which we have to follow when we do the optic disc evaluation. Like you start with the scleral ring, then you come to the NRR health, then you talk about that where do you see those baby vessels emerging out. It is not about that yellow color which you see and you say that it's a cup and the other remaining portion is disc and the NRR is there. No, you have to look at and concentrate at the baby vessels. So that's how, and then when you see, and then you see in your beginning phase that ISNT rule has been followed or not. This is how you can evaluate the disc correctly, instead of simply going and saying, and also always compare the disc size. Whenever you say that it's a cupping increased or decreased, always have an association with the proportionate size of the disc, which is really important. And along with that, look and go for the pallor as well, to say that whether it's a glaucomatous cupping or cupping due to any other reason. And as I have already said, it's a neuropathy which is manifesting as cupping. It's not the disease itself, it's a manifestation of the disease. Thank you.
Thank you very much. Over to you, Dr. Shubhranshu.
I'm very much in tune with what Dr. Chaudhary said. Clinical evaluation of the patient is most important. In all the three cases that I discussed briefly in my presentation, these were patients who were put on various anti-glaucoma medications based on OCT, based on perimetry findings. Like no one bothered to check the retina properly, no one probably did a dilated examination, and hence they were putting drops for something and they had some other disease. Second is, whenever we are looking at any neuroophthalmic situation, like we always tell people that pallor out of proportion of cupping definitely points towards a neuroophthalmic disease. And similarly, in perimetry, if there's something that is respecting the vertical midline, then definitely we would have to think of something neuroophthalmic. Thank you.
Thank you very much. And Dr. Anujeet?
So just to reiterate what Sir initially said, so usually retinal diseases that on presentation mimic glaucoma are no-brainers, but however on sequelae, for example, if you have a retinal vein occlusion, many years later that is just a couple of sclerosed vessels that you can see in the temporal periphery. So proper documentation of these findings, having a second look at the fundus whenever you have a doubt, can help you differentiate especially diseases like vascular occlusions, which is very commonly, and post-laser PRPs that can mimic glaucoma on visual fields. So always have a second look at the fundus before you interpret visual field if you have a doubt.
Thank you very much. And is there any question from the audience? And yes, please.
Any variation in the optic disc in cases of normal tension glaucoma or low tension glaucoma?
I'd like Dr. Satyan to please answer that. I can see him there. Dr. Satyan. You didn't hear the question? Yeah, can you just repeat the question? He's there. Can you just repeat your question once, please? Yeah. Dr. Satyan is right there.
How about optic disc variation in cases of normal tension or low tension glaucomas compared to the other situation where the pressure is high and we know about the disc changes?
Optic disc variations, I'm not clear what exactly is the question.
Optic
disc variations
in normal tension glaucoma.
I don't know what exactly, I am not able to understand. Optic disc variations means?
Can you come down?
Is it a masquerading that you are saying, or optic
no.
disc variations in NTG?
Optic disc variations in NTG, if there is any, apart from...
Vis-a-vis glaucoma, vis-a-vis full-blown glaucoma.
The only thing is I can say about RNFL rather than optic disc variation. RNFL pattern is little different in a NTG, which is more closer to the papillomacular bundle. That much I can tell you. But is there a change in the optic disc? I am not sure. But RNFL, yes, definitely. The pattern of the RNFL is more closer to the papillomacular bundle. That is one thing which we can really say. The second thing is probably the disc hemorrhages are much more common to see in NTG pattern. Other than that, the cup part of it is almost, same as what you see in your regular open angle glaucoma. I won't say it is like angle closure disease. But
what are your parameters to set target pressure in such situations? Low tension or normal tension?
See, in the normal tension glaucoma, again, it is depending upon one type of NTG is like a non-progressive type. You have another one is a progressive type. In a progressive type, you keep it somewhere around 20 to 25% as the minimum target pressures. But having said that, it is not that every patient will be getting arrested by that 20 or 25% IOP drop. So there's a lot of variables that we have to look into.
Yeah. So we have some glaucoma
I'm not
stalwarts.
sure whether I'm answering is...
That's all right. I'll just move on to we have some glaucoma stalwarts in the hall. Dr. Shushmita is there. Could you add something to it? Dr. Tanuj is there. Dr. Murli is there. If you want to add something to that, please.
Yeah, I will give the point to them.
Yeah.
I think where optic disc changes are concerned, of course, optic disc hemorrhages would be more common in normal tension glaucoma.
Yeah.
And you have more of an ischemic etiology rather than mechanical. So sometimes they might appear a little more pale.
Yeah.
And the defects are more towards the horizontal, as we've just talked about, rather than the poles. And therefore, there are central deep defects which reflect in the OCT in the GCA going before the RNFL.
Absolutely. Dr. Murli, would you like to add something to that? Normal tension glaucoma and POAG. Mainly disc features.
Thank you for the question. The basic interest in looking at the disc in glaucoma, I think it's very, very important that you diagnose the glaucoma based on the disc appearance. There are certain very typical features of glaucoma looking at the optic disc. We all know that. We teach the classic notch in the rim, the bipolar notch, the RNFL defects, the increase in peripapillary atrophy, watch for the progression and so on. What you can say as maybe typical NTG. NTG basically would mean some kind of maybe a circulatory disturbance, something to do with the blood flow as well. So that's why maybe you can probably find disc hemorrhages appearing on and off and then going away over time. So serial disc photography and looking at the pictures over time will probably tell you the sequence of coming and going and then what's actually happening as a vascular episode in that optic nerve. Otherwise, there's nothing really specific in terms of say, giving it a high degree of specificity and saying that this particular disc is typically NTG or this disc is something else. It's very difficult to say. It's a lot of subjectivity with that. So you can't really conclusively say, looking at the disc, this is NTG and so on. It's all put together, the open angle, the intraocular pressure, the diurnal variation, the typical nature of what you see on the disc, the correlation with the field, all put together is a clinical picture of NTG.
Yeah, so you cannot actually differentiate it on a straight line basis with primary open angle glaucoma, but definitely NTGs have more notches, disc hemorrhages, and of course the intraocular pressure is much lower. That's how we think that it's an NTG, because the intraocular pressure is lower than primary open angle glaucoma, basically. Anybody else? Do you want to add anything? Anybody from the desk? Yes, please. Carry on.
Hello, I just have another question. Is it okay to go ahead?
Yes, please, go ahead.
If OCTs are, now that OCTs are available in our regular clinics, if there's a situation where all my other parameters seem stable, like for say the IOP is fine and the disc looks same as the last visit and the visual field seems to be stable, but the OCT, RNFL and GC, or either both of them, the RNFL and GCC is showing a progression, or one of those parameters is showing a progression, do I take that as progression and modify the management, or do we looking at the whole picture? Because if I didn't have OCT available everything else would have looked stable and I would have probably not modified the medication. What do we do in such a scenario?
Yeah, so what would you do in that dilemma, Dr. Chaudhary?
The question is something tricky is there, that you don't have OCT, treatment is different. We have OCT, the treatment is different. Is it?
No. If knowing that if I didn't have the OCT,
Yes.
I know that everything is stable. But now that I've seen the OCT, RNFL or the GCC which I had available, I can see progression in just the OCT, RNFL or the GCC analysis, but everything else like the IOP, the optic nerve or the visual field, all the other parameters which we usually look at when we are thinking of progression look stable. Even at that point, do we modify the treatment or do we wait for another visit?
Yes, that's one thing. Yeah. Just Satyan want to speak.
I would not modify the treatment. I would wait for follow-up, but yes, please. Dr. Shushmita, Dr. Satyan, both of them want to speak here.
Actually, it is a good question. Everything else is okay. The optic disc appears fine, the visual fields appears fine, only the OCT is showing a change. But in that way, I would really look at whether is it really true that the disc findings of your subjective examination is okay or not. That is first thing. Second thing is visual fields again is subject to a lot of variables. That is, so I just take it as definitely it is okay, and only the OCT is showing the change. When you're doing the OCT, especially when you're looking at the GCL, again it depends upon the which equipment which you are using. Say for example you are using the spectralis, which gives you 1 to 2 micron variability, and when you are using the others, I don't want to name any other company, it gives you a variance of about 8 to 10 microns in the GCL map. So when you have such a variability, the company itself gives you, if it is the change is between 8 to 12 or 8 to 10 micron change, then you say there is a progression over a period of time. If it is not so, then there is no real progression happening. But the variability of about 25 to 30%, you got to be extremely careful about reading your OCT. So that will be my very short and crisp answer for that. If it is really giving a significant change like 15 micron change or more than 12 micron change in a different kind of OCT, but in spectralis it is of course a little different. Even spectralis gives you minimum change of about 8 microns, then you say there is a possible progression. We are not saying it is a progression, we are saying a possible progression in that.
To know so even a change in it likes Satyan better. Okay, so even a change in signal strength will lead to progression, and increased cataract would lead to progression. So the OCT has to be looked at that the parameters were exactly the same before, you do it on the same day, you put in a lubricant, and the red will become an orange, and an orange might become a green again. So, but still, having said all that, and if everything else is fine, if I see a change in OCT, it would make me follow up the patient a little closer, because it might not be confirming a visual field progression today, but maybe if we saw it 4 months down the line, it would. But like Satyan said, we are definitely wary of, having a knee-jerk reaction and treating. So unless once you see change, it's an indication that, okay, just keep a watch on him. But functional progression would be when I would change.
Thank you, Shushmita.
Thank you so much. Can I just add on to that? It's
yes, please.
It's the other side of it.
Yes.
Just asking the dilemmas that I actually face. If the OCT is fine, the OCT is fine, the IOP is fine, and the disc looks fine, and sometimes we come across the visual field, which is not reliable, not very reliable. It's it looks like the same, it's not absolutely haywire that it doesn't look like the last pattern, it does, and that is showing some progression, but at the same time it is not reliable. At that point, do we just repeat it and wait, or we would repeat it and wait?
Repeat and wait.
Yes, definitely. We'd repeat the visual field, maybe the next day or after a couple of days, and then we move on from there.
Just I want to add something else. Look at the pupil size when you go for a repeat.
Okay.
You have to, we have to see the what the people said before and after that also. There are lots of fallacies come. It's a minute changes there. So the technician part is very important in this case also.
And always differentiate between a pseudo progression and a true progression, what ma'am was telling. That's really important, because before you stamp anybody as a progressive disease, go for at least minimum of 2 or 3 fields or OCT, whatever you are thinking, that is showing progress. And if that is consistent in all the visits and you have cleared out all the media and everything, then label it as a progressive disease, and then you can take the measures. But solely depending on any technology and changing your treatment regime is not recommended.
Thank you so much.